Sorry about
NCLEX is
that.
not-
I'm having technical difficulties. You have
That's
post
okay.
access, Dr. Capri.
That's okay, Meredith. I really didn't say much until now anyway, so.
You have post access as well for sharing.
But so the idea that, certainly came about with all that research, plus the National Council's own research. The fact is, we're not teaching our students to think. So even though we've all been saying probably for the last 30, 35 years, sure, we teach our students to think, it hasn't been working. And the measurements that they used to, at least Kavanaugh, Sharpnack, Kavanaugh, and Suida, Del Bueno, what they used, of course, right away, when that came out in 2017, I said to myself, well, that's because the practice side is expecting them to think at too high a level. They probably give them very complex case scenarios because they're given case scenarios. They have to answer basic questions. What's the major issue? What's the problem that needs to be addressed? What would you do about it? What do you think is going wrong? What would be your first intervention to help this patient? I'm like, well, these are probably critical care, complex patients. They're expecting way too much from that new grad. I got this figured out. I know what's wrong. That's what's going on. So I contacted Dr. Kavanaugh from Cleveland Clinic. Well, actually, I did contact her, and we wrote a guest editorial together, actually. But first I was working with HealthStream. I don't know if some of you are familiar with HealthStream. They do a lot of onboarding in the practice setting. And they said their number one issue is preceptors do not know how to give feedback to new grads who are not able to think. They say, well, your thinking's not very good, but we just don't really know what to do to help you. And so they were using my framework with their preceptors to guide that new grad's thinking. And I said to him, the fellow I was working with, I said, Joseph, this research is coming out and they're using Del Bueno's case studies. They're using your case studies because they bought them. HealthStream bought Del Bueno's system. Your case studies to measure new grads' ability to thinking. I bet you, I've never seen your case studies, but I'm guessing that they're way too high level. And he said, Lynn, do you want to look at them? I said, sure. Now this was after 2017, probably about 2018. I said, yeah. So he let me look at the TED Med-Surg ones, because that's adult health is what I always worked in. I looked at them and he said, these are the ones that Kavanaugh used. These are updated ones that Del Bueno used. So see what you think of them. Oh my gosh. They were easy. They were one issue. One that I remember, a fellow, like 65-year-old salesman was admitted to the hospital with something. I don't remember what it was. It wasn't a cardiac problem, but he had, he smoked, he was overweight, he had a high stress job, he had a lot of anxiety. And so the nurse went in to assess him, and the nurse, he was saying, I don't know, I don't feel so good. I feel a little achy. My jaw hurts and my left arm hurts here. I don't know what's going on. They did not realize he was having possibly signs of an MI. And that's all it was. Plus they did the assessment, they gave him some data of the assessment for whatever the problem was that he came in with. Might have been a GI bleed, I don't remember. But I'm thinking, oh my gosh, if they missed something so obvious and basic, this was not critical care. So I think these research studies that demonstrated and these were all on RNs, the RN's inability to think at entry-level expectations, they were fair. In fact, they were probably pretty simple. I probably would have expected them to have more complex kind of other pre-existing conditions interfering, but they really, really didn't. And of course, y'all know that it didn't matter and you're all probably familiar with this, so I'm just kind of summarizing why we need to change the way we teach them to think. But it didn't matter in that research if that new grad had an associate degree, a baccalaureate degree, or a diploma, as there are many diploma schools out east yet. So it didn't really matter. The ability to think was no better in a BSN than an ADN than a diploma. So what are we supposed to do? What do we need to do differently? Obviously, the way we've been teaching thinking over the last 30 years is not bringing us to where we need to be with helping our students how to think. So all of this research has come out of the National Council with their next generation NCLEX, their clinical measurement model. and about these 6 cognitive processes. How do you teach to that? So most of what we have out there, in fact, I haven't found anybody yet, but everybody, mine is different. Now, the National Council says we should use a framework. You know, they have their 6 cognitive processes. That's what a lot of vendors use. We're going to help you drill your students on thinking related to these 6 cognitive processes. But I don't see anyone else, and I don't know why, because I've been talking about this since 2000. I put this process together, not in the last few years because the NCLEX changing. I've been researching this starting in 1980 till 2000, trying to figure out how to teach thinking. And that's when I started with this framework and kept, maturing it. Just happened to be where we can now align it with the next gen NCLEX measurement model, because there's these 6 major processes. If I just ask, and this is the approach from most, if I just ask a lot of questions and I say, okay, this question relates to this cognitive process of recognizing cues. This one relates to this question of prioritizing. Now you're learning to think. No, you're not really learning to think. You're just giving me practice answering questions. And if I answer it correctly, you assume that I know how to think. What cognitive processes are you using? The National Council says we have to use a framework to teach clinical judgment. And if we just have these 6 major cognitive processes, they don't really tell you what specific thinking needs to occur when you're recognizing cues. What is the thinking that needs to occur? Theirs is a clinical judgment measurement model. It's not really a model or a framework for teaching thinking. They're just telling you how they're going to measure it. So we need to drill down to the detail, like with most things. We drill down to the detail all the time for teaching skills. And if you look at the way you teach a psychomotor skill, especially when they have to do a checkoff on, right, or a return demonstration or whatever on, you break it down into great detail. 75 steps to putting in a Foley catheter, right? We drill down to the detail. We need to do that same kind of thing for teaching thinking. It's no different. We're teaching a major concept, but we can't just say, go do some thinking and come out and tell me what you think. Come out and tell me what happened when you were recognizing cues. If they don't know how to do the thinking to recognize cues or analyzing cues, they have to know the thinking that if I'm going to analyze cues, what kind of thinking am I supposed to use? And that's what my framework provides, is the specific detailed thinking that needs to occur with each of these major cognitive processes of the next generation NCLEX. But it also really, for years, for decades, we would say, well, we teach students to think by teaching the nursing process. The National Council will still use the nursing process there, but it's done. And they said, they say this quite often. They said it last year in their NCLEX roundup that, the nursing process is fine and we need to keep teaching it, but it's not enough detail to actually teach somebody how to think. You can't say go in and assess and have them know what they're supposed to do when they're assessing. We have to drill down to the detail. So we've used frameworks in the past to teach students to think. Even Tanner's 4-step frame, 4 steps, that's really too broad. The nursing process, 5 steps, too broad. We have to drill down to the detail. So what I'm going to talk with you about, and what the book is all about, is the detailed thinking behind each step of the nursing process, the detailed thinking behind each of those 6 cognitive processes of the next gen, the NCSBN's next gen clinical judgment measurement model. So it's the pieces, the detail that you have to think, or that you have to teach. In Dr. Benner's Educating Nurses book in 2010, she said, we have to break this large clinical judgment, she used to call it clinical reasoning, concept into its pieces. You have to break it down into its pieces, teach the pieces, and then the student will put it all back together. And that's exactly, what my framework does. And hopefully the approach to teaching using my book should do for your students. The NCLEX roundup last week, the National Council's NCLEX virtual conference last week, they said that with the new test plan, the detailed test plan for both the RN and the PN, that you know how they have those integrating processes, a spirituality, nursing process. I'm trying to think of what the other ones are. They make clinical judgment an integrated process. So any and all questions could require the student to engage in clinical judgment, not just the next gen NCLEX specifically written questions, that they will infuse clinical judgment across all types of NCLEX questions. And they talked about the traditional type of NCLEX questions that were really just focused on a specific point in time or specific content, very kind of a skeleton kind of a STEM, that the importance is to wrap more clinical information around those STEMs. So even though it's a traditional type of question, it's still going to require the students to be able to know how to think. So it'll be across the entire exam and across all of those detailed objectives in the detailed test plan. So it's now going to be with a new test plan starting April 1st in 2023, integrated across. I think originally the idea was, well, you know, they're all going to get three case studies in their first minimum number of test questions everybody takes, with 6 questions in it. So there's 18. So they got 18, but all the rest will be the old style. They're saying, well, they'll be in the old style, maybe 4 options, maybe select all that apply, but they still will require the student to be able to think. They'll still have some clinical judgment infused into them. So it's going to be important, not just for, for those 3 times 18 clinical judgment questions that all students will get. Now, if they go beyond the minimum number of questions, then about 10% of the questions will be the specifically written clinical judgment type. Okay. All right, so let's see here. Let's share the screen and we'll talk now. I'll just talk specifically about how to teach in your program using the textbook that I think you're going to start using next semester in winter of 2023. Okay, so how do you teach it? The best way to teach it is always to teach it in the first semester of the program. Now, a lot of schools that are using my textbook and using the online course even, they're integrating it, trying to get their seniors up and running for the NCLEX. They're going to the next gen NCLEX. And so they're doing kind of a quick and let's get it in the fall semester, and then we'll apply it a lot in the spring semester. And hopefully when they take the NCLEX, they'll have a little better idea about what clinical judgment is all about. But to me, it's a fundamental concept. You know, nursing process was always taught in the fundamentals course. And so if this is the thinking behind the nursing process, it should be taught in the fundamentals course, because it's a concept fundamental to all areas of nursing. And this one particular approach, just like the nursing process, is used in all patient types of situations, OB, peds, home health, med surg, all of them, mental health. This is the thinking behind it. So the same framework is used in every type of patient situation. So it's not something different for home health or something different for med surg. It's the same approach. So this is, of course, as you can see in the book, these are my 5 steps. I used to use the 4 steps of Tanner, and over the last 4 years using Tanner, 5 years. Well, I've used Tanner since it came out in 2006, but using it to really specifically teach. Tanner doesn't have all of these thinking skills or clinical judgment competencies. It's just 4 steps. I realized that those 4 steps, you know, her model came out 16 years ago. So I don't feel bad with thinking maybe it's time to revise it a little bit. So I revised, and I don't use strictly just her 4 steps. I really think there were some things missing, and so I expanded it. And so that's where these 5 steps are coming from. So my 5 steps, getting the information, of course, I can't use the language of the National Council's clinical judgment measurement model, but their recognized cues, they're getting the information. And NP is nursing process. So in the nursing process, it's assessing. What kind of thinking do you do? Does the nurse do? So if we're going to teach them to think like a nurse, what kind of specific thinking does the nurse do? Here are 5 clinical judgment competencies. I used to call them thinking skills that a nurse does when a nurse is getting the information, assessing, recognizing cues. And then based on that information, we need to take to the next step. So they're learning this throughout the whole first semester, making meaning of the information, which is analyzing cues. That's the National Council's clinical judgment measurement model. And of course, in the nursing process is the diagnosing. And so in this particular step, we have 9 different thinking skills that need to go, or clinical judgment competencies that the student needs to engage in, because the nurse engages in this kind of thinking. See, we've never really written out the specific types and listed the specific types of thinking that a nurse does in each of these steps over here of the nursing process, which is what we've taught for years. What exactly is the thinking that we do in it? And this is the thinking that the nurse does. And diagnosing, they have to make meaning of all that information by applying those thinking skills or clinical judgment competencies. You will see that none of these clinical judgment competencies that I'm listing, I didn't make any of them up. It wasn't, well, what do I think I should call that? All of these are scattered all over your nursing textbooks, are scattered all over the nursing literature. I'm sure you've learned from nursing diagnosis, you have to cluster related information. Analyze assumptions. We teach students all about, if you're making assumptions about the patient, are your assumptions correct or not? There's nothing in here that you haven't taught your students. All of this is from the nursing literature. I'm just organizing it into a framework. Your new students like you to present information in an organized, understandable way. And that's what I'm doing. So there's nothing that is not found in the literature. It's just that it's scattered all over. Some of it is in physical assessment, some of it is in nursing, the nursing process, and what do you do with the nursing process. We've just never taken it and put it all together in a framework and made sense out of it, and then taught it the same way every faculty teaching thinking. That's one of the big issues, is not having consistency. We all say we teach thinking, but we don't necessarily all do it in the same way. So the student doesn't even know if you're teaching thinking or not. They just know that, well, when I'm with Dr. Caputi, she asks me these questions. When I'm with the other instructor in clinical, he asks me these questions. We're all asking those questions to try to get them to think, but the student didn't recognize that. They used to come up to me at the beginning of clinical rotation and say, what questions do you ask so that we'll be prepared? All they see is they're answering the questions. They don't know that those questions are in any way related to their learning how to think. This is what we do when we teach them this in the first semester. And then every faculty uses this approach when working through case studies, debriefing in the sim lab, students working in the clinical with their patients. You want to figure out what to do with your patient, apply the framework. That's what we have to teach them to do, not just, here's a case study. Now let's see, what diagnosis does the patient have? Explain the pathophysiology to me. Let's look at the meds. What should we think about with these meds? I'm working through a case study, telling them what content to do, to pull out, telling them what content to think about. They got to tell me what content to think about by applying the framework. So I'd give them a case study and say, okay, let's get the information. Let's work through each of these thinking skills. What's important information here to collect? When you walk in that patient's room, what do you expect to see when you scan the environment? We have to get them to tell me what information they're going to pull out that's important. That's a shift. That's a shift in our approach to teaching thinking using case studies. Before it was just answer the questions about the case studies. And this is apply your thinking. I worked with a group of baccalaureate students over a winter break a couple years ago, teaching the framework. And then because of COVID, of course, everything was online. And so I'd sit in on their classes. So the faculty were supposed to start taking this new approach using the framework, working through case studies. It took them about a month to do that because it's hard. We've worked through case studies in the past, just pulling out content for students to think about. We've done that for decades. Now we have to shift it and say, no, you tell me what content we need to pull out of there based on your thinking. But it took them a little while to do it. So by the middle of February, they got really good at it. By the middle of March, students were saying, I remember one student said, well, wait a minute, we didn't use this thinking skill yet. Wouldn't it be important to judge how much ambiguity is acceptable? They were telling the faculty which thinking that they still need to apply to that information they collected. That's what we want, because the National Council says that these students, when they graduate and take the next gen NCLEX, they're supposed to be self-directed thinkers, not you directing them. They got to direct their own thinking because that's what's needed in practice. So, and using the framework really helps to helps the student to direct their own thinking, rather than you saying, let's look at the meds. Should we go look at the lab results? What lab results should we look at? See, you're directing their thinking. So this is the shift we need to make. So they direct their own thinking. Otherwise, they don't know what to think about when they graduate and you're not there anymore. And that's what Dr. Kavanaugh was sharing with me with her research at Cleveland Clinic that was published in 2017. She said the students, the new grads, will list what they know about the situation, and that's all they'll look for. They really don't know what else to think about because they were just trying to recall information rather than apply a thinking process to it. And so then we have, of course, the next step in the process is determining actions to take. That's the National Council's prioritize hypotheses and generate solutions. So I think the student will understand a little better what determining actions to take rather than using the word hypotheses. But that's just the planning stage of the nursing process. And these are the specific thinking skills or clinical judgment competencies. And then taking action and evaluating outcomes and your thinking. They have to be self-reflective thinkers and evaluate and correct their thinking. What worked, what didn't work. So in the first semester, these are the 23, let me see where we're at, 23 critical thinking critical thinking thinking skills. That's the old language, clinical judgment competencies, as they relate to each one of the 5 steps of my framework. And each of those steps of the framework relate to the clinical judgment measurement model. So in teaching these, you're teaching them and preparing them for the NCLEX. Okay, that piece of the NCLEX, not the content. Hopefully the content they'll learn as they go through and work through all of this with patients. But it's the thinking part that is now an integrated process with all questions across the NCLEX. Okay. So we teach all of those. Let me go into here. So how do I teach all of those? And that's what's in the book and in your faculty resources. So this is from the other document. It's on page 12, approach to teaching each clinical judgment competency or thinking skills. So these are the 23 clinical judgment competencies that hopefully are being taught in the first semester. And there's a process for teaching each one. We can't just say, okay, here's the definition of scanning the environment. So now we're going to scan the environment. We have to really, kind of keep it simple and make it understandable and doable. New students coming into your program are just going to be overwhelmed. And so we have to make what we're teaching them understandable and something we say, you know what, you already know how to do this. We're just going to make you aware of that. And then we're going to take that thinking and apply it to nursing. So each of those 23 clinical judgment competencies, I would teach this way. Start with the definition. So you're going to define it. And this is in the book. Give an example using clinical judgment competencies in everyday life. That's step 2. Because what we're doing is using cognitive learning theory, which says we're going to take something you already know and connect it to the new information, and it'll make learning the new information easier. Because they can connect to it, they can identify with it. And so we give them an example, and this is in the book too, of using that clinical judgment competency in everyday life. You already know how to do this. So their homework might be read about that clinical judgment competency and then bring to class an example of how you already use that thinking skill or that clinical judgment competency in everyday life. How do you use it? When and how do you use the thinking skill of scanning the environment? Have you ever done that? You know, every one of those clinical judgment competencies, there's everyday life experiences that are in the book, and the students should be able to bring you, oh yeah, I do that. You know, if I'm going to a party in a neighborhood that I've never been in before, I look around the neighborhood. If I'm going into a house I've never been at before and there's a lot of people there at a party, when I walk in, I'm going to, you know, kind of scan the environment, see, is this safe? Where's the exits? You know, what do I need to think about here? So yeah, you scan the environment. You just never called it that before. We're just taking the thinking you already do, giving it a name, putting it in a framework, so you can now use it in an organized way in new situations. And then the next step in the classroom, when I'm teaching this, provide a nursing example. So the book has nursing examples, simple nursing. These are brand new students, simple nursing examples that they would understand. And so we talk about that a little bit. And you can certainly expand on it and give more examples. On step 5, provide an additional classroom activity applying that clinical judgment competency. Now, the document I'm in right now is the 86-page faculty resources that come with the book. And every week, you know, I had a semester week of what am I blocking? What to teach each semester, each week, a weekly outline, topical outline. And in there, I put the learning objectives as well as classroom activities. So there'll be an additional activity you can do in the classroom that will help you, the students then apply. Okay, so it'll be a nursing application, very simple, and they're in this handout with the faculty resources. So the students can work as a group and apply that thinking right away in the classroom, and you can start helping them along with doing that. Then to me, one of the most important pieces is step 6. They should then immediately take what's in the book. There's every one of these has very simple activities, clinical judgment activities that they can take into the clinical and immediately apply it to a patient situation. You want them to become confident. Oh, I just learned about this. Look, I get this. I can do this. Or I'm going to try it and my faculty is going to give me some feedback. So it's important that we use each of these 6 steps. So in the previous handout, the first one, the shorter one, here's an example. If you're teaching the thinking skill of or clinical judgment competency, predicting potential complications, this week in clinical, they'll take this very simple 4 questions based on your current level. So what do you know so far about nursing? Use that to answer the following questions related to your patient. What are you on alert for today with this patient and why? What are the important assessments to make and why? What complications may occur and why? Based on the above, what could go wrong? Predicting potential complications based on their current level of thinking, of nursing. And these are not in the book because every school kind of has their own way of grading clinical, but I would, if I were you, I would develop grading rubrics. So every faculty teaching any section of that one course. So you have nursing 101 fundamentals. You have 100 students and say you've got 12 different clinical groups with 12 different clinical faculty. They all should be grading it the same way. And they can give them immediate feedback then while they're on the unit. We have to maybe change up a little bit the way we do clinical to provide that kind of time. So we need to really make sure that they are then going into the clinical and applying what they're learning that week in class immediately. And that really helps to boost their confidence. The reason we do this cognitive learning theory approach is to really engage them in thinking and empower them. To empower them to know that, wow, I'm not a nurse. How am I going to learn how to think like a nurse? You already know how to think. So you already are doing this. A nurse uses those same thinking activities and applies them to nursing. And then we just call it clinical judgment when we're applying it in a clinical situation with in nursing. So it helps to empower them and give them the confidence. That's why I think in the first semester, it's so important to do these kind of activities right away in the clinical to give them confidence that they know how to do it. You know, these kind of activities and there's one for every one of those 23 clinical judgment competencies that you're teaching the first semester. You can use something like this across your program. And so you can see if there's gains in thinking. You could use this one in first semester, second, third, fourth, and by the fourth semester, their answers should be much, much more complex compared to what they did in the first semester. So you can use it to measure gains in thinking. So again, with this beginning first semester, and I don't know where you have your pathophys or where you have your pharmacology courses, but you can use, remember, this is the way nurses think. And so they're can apply that thinking to applying what they know about pathophysiology or pharmacology. So when you teach patho, you can use this approach. Oh, I'm sorry, this one's pharm. Couple pages later, it'll be the patho. So what's the name of the medication, the basic information? And then what you really need them to know is, here's the information about the med, but how am I going to use it with this patient? Boy, the National Council in their last virtual conference, they kept saying over and over, it's what do you do with the information? That's what counts. They were saying with this 2023 NCLEX that you don't really need to teach your students to memorize lab results anymore, because if they say, here's a patient with a hemoglobin of 8, they will give the normal range. So they don't have to first decide, is that within normal? They have to decide, what is the meaning of that and what am I going to do about it? So they'll give them the normal ranges if they give a number of value. Oh, so Maris, you're saying patho and pharm are both prerequisites to our programs. Okay, so they've already learned that content. So when you're using patho in a patient situation, you can say, or a medication that they're learning, you can say, let's go back and write here some brief information about it, and let's apply now what you learned in pharm to the patient by asking these questions. So you might have to do it that way. Okay. So you can, again, and these are just beginning questions. You can ask, you can change those up. This isn't meant for you to definitely use these questions every time, just examples. But it connects what they learned about pharm. It connects what they learned about patho to a patient situation, which again is what they kept saying in that last NCLEX conference. It's not, do you know the information? And we all know this, but what are you going to do with the information? And so that's how they're infusing that clinical judgment across all exam questions. It's what do you do with it? That's more of what they're trying to get more to test that kind of approach. So that's very quickly the way I would use it in the, or teach it in the first semester. And so that they have this base, and that's what fundamentals is all about, a base of the basic concepts and how do we use them in all patient situations. And so now they have that. One thing that's a challenge for faculty is all faculty really need to know the framework and what it's all about, and then consistently teach it as a program-wide approach. Because if you don't, it'll just go away. You know, it'll just go away like anything else, and that they learn and then never use. And think about it, you already do this with so much content already. You know, when you teach the pain scale, you don't teach a different one each time. You know, it's 0 to 10. It's 0 to 10 3 semesters later, right? And you all kind of use that same. You all use the same nursing process. You use the basic skills checklist for whatever skill it is. But then what you do is you say, well, this is how you learn it in lab. Yeah, you may never do it exactly that way for every patient. So let's take it and apply it to this patient. And how are we going to change some of what we did on that skills checklist for this individual patient and which things can you definitely not change, otherwise it'll cause harm. So they're learning to apply, what they're learning in the clinical judgment course, and it has to be then consistently used at those same thinking skills, but how you apply them will be, this is the crux of it. How you apply it will depend on the patient. Okay. And that's a lot of what they learn in that first semester when they go into the clinical. If they're going to do prioritizing patient needs, predicting potential complications, and 2 students have patients with the same medical diagnosis, and you talk about in post-conference, okay, tell us a little bit about your patient. Oh, a patient had a heart attack. What are some potential complications? They maybe came up with different complications than student number 2 with a patient who has a patient who had a heart attack, because they're applying it to an individual patient. And so they're looking at, well, I did a little bit differently this time because based on that patient, it's more important for me to think about these potential complications. And that's one of the big shifts that we're seeing in their thinking. The first semester in the classroom, learning all this stuff, and they're memorizing it, and they think everything I learn is going to be applied exactly the same to every patient. But then when they go in the clinical and they start comparing each other's notes in post-conference using the thinking, well, you did it differently with that patient. Okay, when you scan the environment for that patient with an MI and this patient with an MI, why were you looking for that with this patient? Well, because this patient also has this, this, and this, or because the MI caused the patient to have some renal failure. So we need to make sure we're looking at the diet where this patient, the MI didn't cause it. So they're starting to see the differences, and that's moving in Benner's from the novice stage to the advanced beginner stage, where instead of applying everything black and white, they're starting to learn what you mean when you say to them, nursing's not black and white, it's gray. Oh, it's gray because of these differences. So what I learned about an MI may not apply to every patient the same way. And that's the same thing with doing the skills checklist and taking them to clinical and saying, well, what are you going to do a little differently for this patient? Because everything is nuanced. And so that's part of this. And this is in the book that talks about moving from Brent Benner's novice stage into the advanced beginner. And if you do this approach, teaching this framework in the first semester and immediately applying it in clinical every week, as I'm talking about, they will start to see the what you mean by nursing's not black and white. They'll start to see how you move out of that novice stage into the advanced beginner stage. And that's one of the major accomplishments you want in that first semester. Learning the framework and learning the answers to any of these kinds of activities it depends. It depends on the patient. So those are 2 major accomplishments in that first semester. And then in the second semester, continue to use the same tools so students can master that type of thinking. So they can use those exact same simple tools from semester 1 and semester 2, but they're just putting them, applying them to different patients. And their answers might become more complex because they now know more about nursing. Okay. And you can discuss those certainly in post-conference, post-simulation. So once you learn this, it's applied to all learning experiences that require the student to engage in thinking. You can use this framework to guide your post-simulation debriefing. Okay. So what thinking were you doing when you decided you needed to do this? Okay. So you really need to use it in all situations, because if you're working through how to deal with a patient, that requires how the nurse is thinking. So you have to have a framework for them to use to determine how the nurse is thinking. So use the framework to direct your discussion patient case studies, as I mentioned earlier, so you can actually get to the students' thinking, not just what content to pull out. And then semester 3, you continue to use some of those activities in chapters 1 through 7, where there's actually 3 through 7, but apply to more complex patients. So you can see if the student is pulling out more complex information and putting all of that together. But then you can start using some of the advanced tools that are in chapters 8 and 9 in the book. And so the tools in chapters 3 through 7 each focus on a specific thinking skill or clinical judgment competency. But as I said earlier, when Dr. Benner said, we'll first have to deconstruct and break down the pieces of clinical judgment and then put it back together. So we don't want to constantly across your whole curriculum, just give them practice with individual thinking activities. We want to say, okay, here's in chapters 8 and 9 are activities where you go and you apply that thinking activity to your patient situation. But instead of saying, well, we're going to use one thinking skill to do this. No, you just go and do it. And then after you do it, explain which thinking skills you used and how you use them. So it's kind of now trying to see if you can put all this thinking together. Some of these thinking skills or these clinical judgment competencies you may not use in every situation. Tell me which ones you used and how you used them. So we want to do some of that in semester 3 so we can see that they pulled it all together. Semester 4, students use the steps of the computer clinical judgment framework and all the clinical judgment competencies in the book to explain their thinking, especially in clinical. And you can do this in the classroom with case studies, simulation debriefing, whatever. But what you do is you say, okay, here's the case study. Let's do an unfolding concept map on it. Let's draw a circle in the middle of the paper and do this in clinical with the patient as well at the beginning of the day. And put important information in that circle about the patient. And then when you walk in the room or before you walk in the room even, think about when you're determining important information, just go through each thinking skill in that framework. Determining important information to collect based on what you have in report, draw a line and say, okay, determining important information to collect, I'm going to look at this and this and this and this. And then scanning the environment, draw a line off of that middle oval that you have some of the important patient information. I'm scanning the environment. I expect to look for this, this, and this. And then just keep unfolding that concept map based on the thinking, based on application of the framework, so that you can see that they know how to apply thinking to an individual patient situation. That turns into, across your whole curriculum, that turns into your care plan. That turns into applying the nursing process. It's kind of, it's all of those things that we used to do 5-column care plans after you go home, after, take care of this patient, you go home and you complete your 5-column care plan. We really shouldn't do that anymore. We should be applying the thinking in the clinical where the nurse applies the thinking and having them doing this unfolding concept map that explains the thinking and how they're using it in that patient situation to come up with what it is I need to do. Okay. And so that's what you would do in semester 4. So the important message here really is that before students can engage in clinical judgment, they must first in semester 1, learn the specific clinical judgment competencies to carry out each step of the clinical judgment framework that apply those clinical judgment competencies throughout the program in every learning environment. And this is the difference. And I can just tell you honestly, because I pretty much keep track of what everybody else is doing between what I have to offer and what others have to offer. What others have to offer is fine, but it doesn't back it up and first teach it. Somebody might say, okay, look at, this is what I have. I have a bunch of case studies. Use these case studies, apply these questions. And if the students can work through and answer these questions, then they're showing you they can engage in clinical judgment. I'll even align these questions to which of the 6 clinical judgment competencies of the NextGen NCLEX measurement model. That's application. There's nothing wrong with it, but you can't do just that, because if they never learned it, how are they going to apply it? And so that's typically what you'll see is the approach. Learn how to write good NCLEX NextGen questions and give students a lot of practice with that. Again, that's practice answering questions. It's not really teaching clinical judgment. And we can't assume if they can answer the question correctly that they know clinical judgment and how to think any better than they did previously. Those are the instructional strategies that we've always been using. Ask them a lot of questions, use some case studies, and see if they can answer your questions about the case studies. We have used that. And that's one thing I'd like you to think about here are the instructional strategies. If we use those same instructional strategies, are we really teaching thinking? And those same instructional strategies, look at the results of the research that it's gotten us. We have to back it up first and teach clinical judgment so they have a process to use when they're answering the questions. That's what we're missing in nursing education for decades. So think about the instructional strategies. Both of those are okay, but the one where it's just work through these case studies and ask questions, that's not actually teaching, that's expecting them to already know it, which is what we've done for decades, already know it and apply it. What I'm offering for you and what the National Council says we need is a framework to first teach clinical judgment so then they can apply it. I know we're getting to the end of our hour. I just want to say some schools that I've worked with will blow this, where do we have it here? We'll blow up this and make a very big, like a poster size of the framework here, all of this over here with each step, and put it in the classroom. So when they're working through case studies, you don't have to try to remember all of these thinking skills or clinical judgment. They're all right there in the classroom. And you can say, okay, let's start at the first one. Which one of these clinical judgment competencies is, or should we be using to start our case study discussion? How are we going to then, after we've done this, let's think about measuring, making meaning of the information. Let's work through each of these. Okay, clustering related information. How would you do that with the information in that case study? So they'll blow it up and actually have it in the classroom that they can kind of follow along. And other schools will take this column here along with the one of the major steps labeling each of these, and they'll shrink it up into a little postcard size, and the student and laminate it, take it to clinical and pull it out as they're talking to the student and talk in terms of the thinking that's being done. So just kind of like little cheat sheets that we can have available for us to teach the students, and that the students can certainly have to guide their thinking as we expect them to, because that's what our questioning should all be. Not necessarily what are the meds the patient's on, did you look at those, but really, so what's important for you to determine important information? When you've identified signs and symptoms, how will you know if you've assessed systematically and comprehensively? And maybe then they'll say, well, I need to go look at the meds. Unless I know if the patient's on a certain kind of med, I won't know if that's why I'm getting this blood pressure or this pulse. They need to tell you they need to do that, because that's what the self-directed thinking nurse does. All right, I think I've reached the end of my time. Oh, I've got 1 minute left. So I hope I didn't talk too fast. And I didn't put some of you, Linda, I hope you're feeling better. You look really kind of tired and fatigued there. So I hope you're doing better. But that's what I wanted to share with you today. And so any questions, comments? Stop share. There we go.
I have a comment. Linda, I met you at a conference and you just knocked my socks off. I don't know, maybe 4 or 5 years ago, but in any event, I'm reading a lot about generalist practice. I hear that term a lot. Sometimes it's used in a derogatory fashion, almost like we're trying to get everyone to be just like a med surg nurse. And I think that your framework helps support the notion of generalist practice, meaning the same thinking skills are applied, but it's context specific. And I really like the way that framework supports that idea or concept of generalist nurse, generalist practice.
Yeah, AACN, I think, uses that term and used it in their previous essentials. And to remind us, we're not making critical care nurses or labor and delivery room nurses, but that's an excellent point, Christy, that a generalist nurse takes the same approach, though, no matter what environment they're in, for sure. Another term I have trouble with a lot is your students should be practice ready. Yeah, let's get a definition of that, because that doesn't mean they're going to hit the floor running and take care of, full patient load in the first 2 weeks. We need to really describe, I think all schools of nursing should describe their own, what they mean by practice ready. I'm going to send you my student, and that student is practice ready, and this is how I describe my practice ready student. One of them will be they know how to engage as a generalist using a clinical judgment framework, no matter what kind of patient they're taking care of. That's practice ready. I think we need to really clarify that term, because can you imagine the differences in opinions about practice ready from a school side and a practice setting side? We need to come together on that. So I think that's really what we need to do. And I think some of what you're saying, Christy, can be used in that definition. Yeah. Any other questions or comments, or is it time to crawl back into bed and take that afternoon nap?
Libby has a question.
Yes, Libby.
All right. Thank you, Dr. Caputi. It was wonderful hearing you. And I think reading and then hearing you explain how that can be integrated into the first semester made a world of difference for me today. So I thank you for that. I do teach in the first semester, and we've already been talking how we will work together, fundamentals, and I do the health assessment, how that will work, but it really is helpful. But can you tell me in regards to your online class, do you have a recommendation when that should be taken, or can that be taken anytime throughout the program?
Well, the intent of it was, so many schools I worked with that have adopted the book, they'll say, Linda, it sounds real great that we're going to teach this, but we're already overloaded. Don't you have a supplemental course that can teach it, and then we can just apply it and answer questions and, do the application of it in the classroom? And that's why I did the online course. So the online course right now is being used by quite a few schools in place of classroom teaching of that in that first semester.
Oh, okay.
Because what I do with it is, and I do all of those narrated PowerPoints, but I add to it as if I were in the classroom. And let me give you this other example, and let me do this. And then there's practice activities in the online course that they can complete, that you can look at. And then you can take the information that they've learned and their practice activities, and then go into the classroom and say, now you've learned that. So it's kind of like the flipped classroom. You learn it before you come in. Now we're going to apply it in the classroom. So that's the way most schools use it right now. Depending on what you have in your program, it probably in how your students are doing, it might be a good supplement if you don't use it in the first semester, maybe the beginning of the second year, to remind them of what they've learned in the first semester, maybe augment it because I do expand on the content in the online class. So you could actually use it that way as well. But right now, all the schools that are using it, and I have practical nursing programs, associate degree programs, baccalaureate programs that use it, and they're using it in place of classroom instruction and to use it to augment and then come to class to do application activities.
Okay, thank you.
You're welcome. Maureen.
Yes, thank you so much for taking the time with us. I really enjoyed, and I've been diving into this book and really thinking. I teach community health, and I'm really trying to find a good case study to unfold. And I just wondered if you had any suggestions in that regard.
Were you talking about community health, or are you talking about home health or community health, where you have problems such as homeless, and how do you deal with homeless people and people who are, they don't call them homeless anymore, do they? Unsheltered or something like that?
Yeah.
Which is, probably a nicer term, and I'm all for that. But, for that kind of thing, and there's a population-based kind of case study.
No, I think we cover that in a pretty good perspective, but I would really love them to come into the community, be able to pull their med-surg skills, and assess and go through the framework in a community setting and be able to make a clinical decision. So really looking for that synthesis of everything to where they're at right now. And so that's why I was just like really kind of searching for a good case study that would be, that we could really unfold, and just playing with it right now, and just wondered if you had any suggestions.
I don't have any specific, but we talk, a lot of schools, we talk about this a lot, and it usually boils down to is you almost have to develop your own. If you really want something that you're really is going to meet your need, but just hearing you, it just sounds like a great opportunity would be you go into I'm thinking about my own, which is where a lot of our case studies come is from our own experiences. But I think about my mother, who used to live in a retirement kind of a setting where there were lots of apartments with different people, and going around from person to person, maybe having 3 or 4 people living in that apartment building and assessing them every week and seeing changes in them and getting better, getting worse, subtle things to pick up on. That seems like a great type of activity where you can, because one person isn't going to have a million different things. And so this way you're going to have, 4 or 5 or 6 different people, and it reminds me of, I worked with many schools over the years where they have like your University of Michigan, I'm sorry, Flint. Yeah, so you might have the Flint community or School of Nursing Flint community that care, and in there they put together patients, their entire histories, their charts. They came into the hospital, then they went home, and then the home health nurse went to see them. So all of this was all done, and they went unfold across their whole curriculum, actually. So of course, that's a big, huge project to do. And right now, I don't think most people have time for it, but it really is, I think, what you can do where you can own it. So you could have some of these people in fundamentals before they ever went and moved into that apartment. They were living, whatever. But I think you almost have to put together to get really what you want, your own. But I think it'd be ideal to use like this apartment building where my mother lived, and just have 5 different people that they might see over the course of your community, the semester of your community course, and things kind of change. I had a colleague down in Florida, and she did this with teaching pharmacology. She didn't teach pharmacology from the perspective of here are the different, this week it's just drug classification, here's some meds, next week, blah, blah, blah. Every week when they came in, they took care of a village of patients, and they were same patients, but they all had that week, the patient would have issues where they would have to be treated with a specific classification drugs, or they would pull out of, well, remember this patient 2 weeks ago came in because he was, having digitoxicity. Now he has this problem. So she taught everything based on her village of patients. And then she taught a different section based on the old approach. And she looked at final exam grades at the end and to see which did better. And the students who worked from the perspective of patient care did much better on the final exam. And they were so much more excited when they came to class. They would come to class, she said, where it got to the point where they would say, well, how is Mrs. Smith doing from 2 weeks ago? Remember, I'm kind of wondering how her wound's doing. And well, she encouraged it because, she would get, oh, here's a thank you card we got from so-and-so, she loved the visit you did last week or whatever, when she came into the clinic. So, she kind of encouraged that, or she would even bring candy, or Mr. Jones sent us some candy. Remember, we took care of him 2 weeks ago. And they really, that's so much better. So I'm so happy that you're looking for these kinds of experiences for your students, because it makes it so much more meaningful. But you probably have to, would be, because you got nothing else to do over Christmas. This would be a good Christmas activity to do over break, right? Put these patients together. You almost have to make your own.
Thank you so much.
Yeah, you're welcome. All right. Well, I appreciate it. Thank you. I hope it's met your needs. If you have any specific questions, Libby, as you're teaching this in your first semester, or whomever may be teaching it or using it across your semester, but I do really encourage you not to forget it as they get into the next semester. And just because you don't teach that first course, you still have to learn about it, use it, and continue to apply it, and use that language. I have a school in Canada who Canadianized the book. So now we have a Canadian version of it, because those schools also take, except for one, I think, province takes the NCLEX. And she was saying that to her, the most value in the framework is the language, to have the language and the thinking skills in verbiage that students can now see in an organized framework, instead of just saying use some clinical judgment or use some critical thinking. That never did any good. I used to remember in the 90s being a little bit embarrassed that when I would do students evaluations midterm in clinical, I'd say, you really got to work on your critical thinking. And they would walk away, and I'm thinking, what good did that do them? I'm not telling them anything. I'm not giving, when you do a skills checklist, you don't say, you didn't do so good on it, come back. You say, oh no, step 37, here's an issue. Step 49, here's an issue. Go work on that, practice it. We give them very specific feedback. That's what we're doing with clinical judgment here. That's the purpose of the framework and the language. Okay. All right, I won't, you need to say goodbye, or I'll just thank you, Linda. I'll just keep talking, but thank you, Linda.
Well, I want to thank you very much. You've given us a lot to think about. I also thank you for allowing us to record it because there were some faculty who are not able to be here today. And it's obvious this is best if it's a true team approach. Mostly we have to hear today faculty that are responsible for the didactic, and I wrote down, oh my goodness, with an adoption of this, there has to be really good faculty development for all of our clinical faculty and to think
Right.
through that because our clinical faculty change semester to semester. So there's a whole process that we need to think about, but you've got us on the road or along the journey, and it will be a process for us as well. And we thank you for your time and expertise in promoting nursing.
You're welcome, and very insightful of you to say that about the clinical, because that's huge. A lot of schools will have a clinical faculty handbook where every week they have these expectations and a grading rubric. So the clinical faculty don't have to try to remember on their own, what was I supposed to do? So good insight on your part to even recognize that that might be an issue. Great. Thank you, and get well, everybody.
Thanks.
Thank you.
Bye-bye.
Well, hi, everyone.
Linda, I'm going to continue to record because some people like Carmen and Debbie were wanted recording of the meeting as well. So
Okay. So it's clear, I mean, we had a few people that are key that are missing. So I, noted Debbie and Melva. We don't have anyone from maternity, Megan, Carmen. It would be wonderful for our student success coordinator that we don't have here, clinical faculty. So there's a whole host of what are our next steps. So Maris, can you pull up the agenda?
I can share it if people want me to.
Oh, Melva, you are here. Sorry, I didn't see you. I've been trying to go back and forth with the participants.
Or is it easier to pull up, to plop it in the chat so that people can access?
Oh, all
I
right.
don't, whatever, what do people prefer? It doesn't matter to
Or
me.
share the screen.
Screen share? Okay.
Yeah, because I don't quite, I have it all up, but then I have a full screen. So do we need to talk about our next steps following Dr. Caputi, or do we need to all spend a few minutes or a week kind of absorbing all that and then having a discussion? I think that you have up the minutes.
Oh, sorry. That's what I was afraid of. I have so many things open on my screen. There we go.
There you go. All right. So we do have a follow-up, in a few minutes. Let's just go through the agenda. Maris, I believe you told me that the minutes were approved.
Yes, we do have approval of minutes. I can do a quick check on the
Code of Operations. Right before the meeting, we were still short of a quorum. So I just ask you to please look at both of these so that we have a quorum, that we can move it forward or know
I
whether
do have a
revisions need
quorum
to be made.
approval on the code now, so,
Okay,
but,
thank you.
but I only have 6 votes, so. I don't know.
so which is just
That's the
barely
minimum quorum, so.
so barely a quorum. Again,
Oh.
having everyone's input to make sure that we're not making errors on any of these would be helpful. But otherwise, let's move on. The announcements that you can see, our first meeting in October will be our regular time. Our second meeting in October, we have again been asked to shift it a little bit based on the dean's request to accommodate it for the executive committee. Student awards, Suzanne, you had an announcement you wanted to make about that.
Sure. So we will be having an email come out with some of the, I guess, awards that are on their way. 10/26 is going to be a deadline for submission of honorary awards, like the ones that will be included in the commencement booklet. And then the deadline for students to apply for Maize and Blue is Monday, October 10th. There's 14 RN to BSN students, 3 accelerated students, and 4 traditional students. So, if you get approached to write a letter, want to write a letter, definitely go ahead and do that. But that deadline is October 10th. So the 3 ASD students are Jacob Danik, Sarah Haycock, and Larissa Stencil. And the traditional students are Adrian Hare, Regina Long, Jessa Parks, and Madison Sills. I think that's it.
Thank you. And appreciate your thoughtful support of students who have shown throughout the program that they are exceptional in different ways and put their names forward. Pinning ceremonies, Maris has some updates.
Just a couple things. I'm working with, I don't know what they're called, the Office of fill in the blank, Building and Events Management or something on our pinning ceremonies, but we are confirmed for Friday, December 16th with a 1 p.m. start for the ceremony that will be for BSN X19. And we will invite the RN to BSN graduates, and then a 3:30. No, I'm sorry, a 3:30 ceremony start for the BSN 55 pinning. Most of those ceremonies, as you know, only last about 1 hour. I've been working with Justin in event and building services in terms of, we really won't need to specify a limit on the number of guests. And at this time, there are no official rules as it relates to COVID code protocol. So in a way, we're kind of back to inviting as many people as we, not really having a cap. The room right now, and we really haven't run into a problem, but we've filled the room pretty well with 42 traditional graduates. Unless somebody brings 20 guests or something, but that's usually not the case. So we're going to do a static recording. It won't be a live stream. So if anyone's been at the most recent events, it's going to be pretty much a cookie cutter of that. The graduates are being informed that they may elect a faculty member to be their sort of cohort pinner. And Christy I'll get in touch with you so the same can occur for RN to BSNs or however they want to do it. And also they'll have a faculty, somebody to read the pinning cards. So that's kind of it. I don't know. It should be on everyone's calendar, and I will periodically dump details as it relates to the pinning ceremony in kind of the notes section on the calendar. So anyway, that's kind of it. But for now, I'm just kind of getting the information off to the students. Commencement has not yet been confirmed yet in terms of a date. To my knowledge, it hasn't been officially communicated, except that it remains tentative as Sunday, December 18th. There was some discussion per Marcia Campbell, who's on the university commencement committee, that they were trying to sort of have fewer commencement events, and that it is possible that nursings could be on Saturday the 17th, but so I don't know anything else about that except that it doesn't impact our pinning ceremony date of Friday the 16th. So that's all.
Okay. And Maris will not impact our location. If they divide it up, is there any possibility we will be?
No, and that was my concern because Marcia shared that at the meeting. And there's no intent for Friday the 16th. There will be no commencement ceremonies on Friday the 16th. So our reservation at the North Bank Center ballroom is safe, which, by the way, I have booked out for about 10 years.
Okay.
So
All right.
that's how I roll. So.
Thank you. So next is our follow-up. And if anyone would like to either lead or talk about that, I feel a little bit dropped in the middle of this because I know that you had discussions last year that led to this meeting. And my understanding, there has been a distribution of her book to either many, most, or perhaps all of you. And then I believe some of the resources that she provided today, particularly the 86-page one, I believe that's new, correct? Or no, it's not new. So I'm assuming that there's some absorption of all that we've heard. And I just open it up to all of you, either for a general discussion. Is this the responsibility of curriculum to think about next steps? Is it all of us together? Where do we go from here? Because I'm dropped in the middle. And then obviously I'll be exiting as more decisions are made about this. So I appreciate any of you who can kind of lead where we go from here.
Hi, I have my hand up, but I don't know if you can see it.
I don't see the hands.
Go ahead,
so
Lisa.
I
I
guess
see it.
either Maris or just please respectfully just talk.
Okay. I just wanted to say that I am using the textbook in the Nursing 435 course, and it definitely probably should be started way sooner. And I think I can see the reason why Christy really liked the choice of books and the competencies that go along with everything. And I can see how it'd be very helpful for like the accelerated group to have the whole book in the fundamentals course, like just that whole book, because their course is a lot faster and some of those same concepts could really be helpful to have them in the later semesters. So it's almost like having for the accelerated group the whole book, and then they could be taught that, and then each section could have be like worked out as they go through the program, maybe highlighting some different chapters or highlighting some different areas. But just looking at it from that perspective, I think that would be helpful. In the traditional group, I definitely think it's a great book in the first course, and I know that she likes to have it broken up. If you look at the book, like she likes to have each, like chapter 1 through 3 is like the first semester, and 4, 5, 6 is like the second semester. I wonder if it would just be as good to like give them a little bit more information than just the first 3 chapters. Because I don't know, I read it. I don't know if everyone was able to read it. Like the first chapter is really the foundation of why she wrote the book, right? And why she wanted to kind of bring together the nursing process and the Nursing Council, State Boards of Nursing framework together. And that's okay for students. I don't think they really are going to care in the foundation course, right? They might want to know the little bit of rationale, but they want to know what to do with all the information. So I'm just wondering if maybe we would even think about considering not doing it exactly the way she may have suggested. But again, I don't teach in the fundamentals course, so I don't know how much information is already packed in there for them at that point.
Lisa, I think you make a great point. I mean, in the beginning semesters, if we take the whole entire textbook and just add it in, they're going to have so much work to do. They're already drowning in homework and new knowledge, right? Which is overstimulating and overwhelming. So as a group, as a faculty group, I think we really need to look at what we should do with it, how we should do with it. Can we, as Dr. Caputi suggested, use it instead of care plans, which would reduce the amount of extra work that they have to do. And the other thing that I have been mulling on, she says, the questioning that we do, and I think we do it consistently throughout the semesters, the Prep U and the U World that Christy used. Can we cut back on some of that type of questioning homework if we're going to use this thinking framework? Okay, it's something that we really need to mull on.
I kind of think that, like anything, we have a wonderful opportunity this semester. Open up the book, play with it a little bit, see how your students respond to it. See, and that's pretty much what I'm going to do, is just kind of open it up. I feel like it's going to help anyways with, synthesis when they get there, or, but let's play with it. Let's see how it feels. Let's unfold it ourselves a little bit and just see where we could develop it further.
I think another thing that we need to think about, I think Christy said it, that we have to really think how we're going to teach that faculty development to all the clinical adjuncts, because it's not going to happen by magic. As much as we might want that to happen, as this is a big teaching job to take out into the clinical faculty.
And Teresa, does that mean that we hone it into theory for a little while and unfold a case, consistently until we see a comfort with it? I don't know.
I don't know, Maureen. I do know that clinical faculty struggle, right? It's an extra job, and there's not always, that faculty development that should be going on. It's, here's your clinical students, go off and make great nurses. So I think it needs to be a really deliberate process, because it's not an easy case. And even Dr. Caputi said, we may have to think of clinical in a different perspective than what we do now, to make the time to use the framework. So more questions than answers.
I think, Maureen, you brought up a really great point. I think teaching, maybe starting it in the classroom and kind of seeing how it goes, and then maybe expanding it to the clinical faculty from then. But I think we need to learn what this process is, how it's going to work, how to unfold it, how to use it with the students before we can teach it to anybody else.
I completely agree, Denise. And I also think that it's, also being deliberate in what we're doing and telling students about the process and stuff. Because if we're just all of a sudden doing a bunch of unfolding case studies, which to me feels like something that I kind of already do, but if I'm not deliberate in the language that I'm using and talking about the different parts, then it's going to kind of be meaningful as we kind of try to scaffold it through. So I agree that it's definitely going to be good for us to play with and to, see how it goes, but then also making sure that we're talking about the why behind it.
So am I hearing this semester is a good semester to individually play with it, look at different chapters, different ways that you're integrating it? Even for some of you that are in Skills Lab or SIM or in clinical, and then provide that feedback, maybe all together, or share successes and challenges together. I wrote that, everything talked about starting with fundamentals. I actually wrote down a note. Would we introduce this in 110? Now I know that that's only for traditional, but could there be some introduction in 110 that the only focus in 110 is on those examples of everyday life, so that when they come to fundamentals, that there might be a little smoother transition to possibly then applying it to nursing. You might need to, fundamentals might still have to start with that application to everyday life, but it's just something to think about. And that's where I didn't know, in addition to each playing around with it in your own course, where is the role, either collectively as a work group for the integration of the computing method? Or is this something curriculum undertakes to say, okay, here's a way that we'd like to see it scaffold among our courses and then between theory and clinical? It seemed clear that at least at some of the places that she worked with, there was like, all the clinical faculty were doing similar things, and that, week 3, maybe these are some of the questions, this is the approach you take in your pre or post conference. But that's, I think, a whole nother challenge for us of what is the similarities and the differences between clinical faculty, and our challenges of clinical faculty being stable in the same course, being between courses, all those issues with clinical faculty development. Just to add to our list, along with integration of
I
essentials.
was just looking at some emails back and forth from Megan and Dr. Caputi back from May of 22. And one of the things that Dr. Caputi noted in an email to Megan was that there is a 3-hour, she calls it a complementary faculty development, but comes with the adoption of both the book and the online course that students would have to buy, which she said was $80. For the adoption of the book, she was doing this 1-hour consultation. But if we commit to, she would give us a more in-depth workshop on the entire clinical judgment framework, how it's structured, how to teach it using the online course, how to use it across the program, but only if we essentially, if the students are obligated to pay into that. Not just buy the book, but also, this $80 online course. So Megan, I think, didn't want to pull the trigger on that quite yet, expressing that it was another expense to students. And I think her response was like, look at our expenses for books and all that. Anyway.
So
'cause I
there's
know,
a
yeah.
separate cost, Megan, or Maris, for that online course.
Mhm. It's like an online development course that students buy. That's $80 plus whatever the book is.
Okay. Do
Um,
you know whether that remains available to them throughout their time, or is that a 1 semester?
I don't know.
Oh, okay.
It doesn't say anything
All
more
right.
about that.
So I guess that's for more further
I think
investigation.
there's more questions about that because how do we go about this? I think that's in her 3-hour in-depth workshop is what she referenced in a May 15 email to Megan.
Okay.
Anyway.
So anyone want to weigh in for the process? I mean, is it playing around with what we have with these courses, trying to make a decision? Are we going to adopt it or not? And to what degree? Are we adopting just the book? Are we adopting that and requiring the course? What do you see as the timeline for this?
I don't know. I mean, the books for winter 23 will be due soon. So sooner than later, when the schedule and whatnot comes out. So I don't know if it's something that we want to decide for fall 23. I don't know what that comes.
Didn't we decide last year before summer that it was going to be adopted
The
for
book.
winter, the
Yeah.
book, the
Oh,
book
okay.
for students? Yeah.
For all classes. See, that's where I feel I'm dropping
Yeah.
in. Thank you,
Yeah.
Teresa.
I thought it was for all classes, but I may be mistaken.
Okay.
I agree. I think that's what was discussed too, that it would be for all classes. What I was going to add is that I don't recall really anything about the online course. And as I was reading the book and trying to think about how this would integrate into my class, that's where the online class information came from me. But I don't think we discussed the online class in the faculty meeting. So, and I just wasn't even sure how that would be used. So I'm not familiar with the class, but it was the book. And I recall that it would be for all students would purchase the book. So that's my recall. recollection on it.
This is Belva. I'm wondering if the requirement is for all students in all classes to purchase the book, and then it's going to be incorporated within the all classes, winter 2023. Unless you guys are sitting around without anything else to do, I don't see how that is feasible. Now, if you said the students have to purchase the book and for all classes, and then the students will get the online class that's already put together, I can see that. But, you know, to say they're going to purchase the book and then in winter, everyone's going to have this in their class, to me, that just seems a little stressful. I mean, I'm just speaking for myself.
Well, and I was also trying to understand, I mean, she talked about starting it in fundamentals and weaving through. So, you know, if we require it for all classes, and as I like say for Melva on semester 4, rather than having those semesters building and the students building, all of a sudden it's new language that they're not even familiar with. So maybe this requires further conversation, but that's what I was trying to understand. Do we need to have either a work group separate or the curriculum committee trying to think about how to phase this in a logical way, both for faculty and for the students? Because if you have a commitment to start at fundamentals, yes, and even if all classes use it to a degree, but those students going through each semester are going to have a different knowledge base. And rather than, as you said, just kind of putting it in for the very first time in, you know, in Suzanne's class.
I kind of, I just saw Melva's chat there, but I kind of agree with what everybody's saying. And would it be something that we're going to start with the new cohort that's starting and then kind of scaffold it in as they go? So you're not going to have every student purchase it, which maybe, you know, would help some of them get the true value out of it if they're starting with it semester 1. So we'd have like the cohort that's starting in the winter purchase it and then kind of go from there. I think from a curriculum committee perspective, you know, I think one of our major focuses this fall is to really get us mapped, and that's going to be coming within the next, you know, basically the next meeting. We're really going to hopefully be talking about that a lot. And not that I don't think that we have the time to really do both, but I don't think we have the time to do both well. And so really, what do we want as our focus from an undergraduate school of nursing, and kind of going from there. I think this is a great book, and I think it's a great opportunity. I just think personally, I don't want to half-ass it, pardon my French. And, you know, I'd rather have the focus be on mapping and getting that kind of well done, and then kind of being able to move on to this, kind of keeping it in mind. I'm very foggy though with COVID, so
I know it's,
apologize.
I feel that way too. So with that, it could be potential that we put it off one semester and actually kind of play around with it this semester, start doing some of the thoughtful integration and mapping of this in winter, and being more ready to implement it in fall, perhaps with an understanding of also an essential mapping, and focus this fall on mapping of the essentials. And also it will be winter. What are the implications of that mapping? And maybe this academic year, you know, we try different aspects of it in our course. You know, if you want a poster of that one page, we could think about that. You could start using some of that language in your courses, whether you the students all have the book or not. So that's just another idea. I really don't, I want you to decide how the approach to take. I'm just trying to summarize and throw out a little bit of a longer period of time that we actually have a thoughtful beginning of it in fall, with the plan this year to do the mapping of both the essentials and the integration of how to go in the course. But if all of you think of this group, that's too long, we move too slow, I'm supportive of that as well. It's up to you. Faculty own the curriculum.
Linda, I think maybe waiting until next fall to implement would be better, because I was under the impression we had this 3-hour training. So how would we fit that in from now and Christmas, plus give people time to figure out how to move forward with this starting in January? So if we even if we fit the 3-hour training in by Christmas, that still gives us the winter semester to think about how are we going to implement this in our courses moving forward.
And the other question I have is, how long is that online class for the students? Has anyone reviewed it? I mean, that might be of high value to prep them, and then our content time would be, lessened because there's already some forethought. But like, I would like to know how long it is, how much does it cost per the student? Maybe we could have one person go through it and evaluate it. Just some thoughts.
Those could be some questions we could ask her, because I mean, I literally have one paragraph that references this online course for students. Yeah.
And I was just going to add, I do think Megan had suggested we all read over the summer, and me and Debbie had been talking about it for winter semester. So I can say that's all we've been doing is talking, but there is no plan after first semester. And I think that was Megan's suggestion, that we start with first semester. And we did think it would be helpful if the students purchased the book and had the book if we were going to start introducing it. And I think that was the only thing that held it up until winter versus fall, so that we would have time to read over the summer. So I'm open to whatever. Like I said, me and Debbie just started the discussion as far as how we would do it for first semester, but I think a better plan would be able to know what happens after first semester and not making that decision the week before that semester starts. So I don't think we went any further. We just said we would read and be prepared to implement in winter.
Hello, Michelle Childs here. I'm brand new to the process, and I can tell you that my brain is spinning, trying to understand the content, understand what's being asked, and how we can support the faculty in the clinical environment so that we're all speaking the same language. So I do see that integrating it in the first semester and then continuing through in scaffolding, it seems like most ideal to me as well. Having a plan for how to introduce it to the clinical faculty as well.
Well, thanks, everyone. Let's continue to process. We can always come back, but in the meantime, I'm hearing that reading the book and trying to implement some of the concepts and starting to use some of the language, playing around with it in your course is what we're doing this term, or could continue to do this term, and we'll come back to this conversation. Is there anything else we want to decide right now or not? Are we okay?
So do I have this summary accurate, that in winter 23, faculty previously supported that the book was to be adopted starting in semester 1, and that per today's discussion, that for fall 23, potentially we could adopt the online course for students, pending more info from Dr. Caputi regarding access to that course and whether or not we may be able to preview it first. And then, depending on what she says, then perhaps this 3-hour faculty develop workshop could occur prior to fall 23, but after the essentials are mapped. Did I get that right?
I think that what I heard is yes, to answer you, yes, but that the plan is that we would have a plan to fully start in fall 23 with the scaffolding and kind of being ready to go. Is that what is that what I'm hearing from everyone?
Okay.
And therefore we'll have to have a plan for faculty development, clinical faculty. I mean, I think ideal if as we roll this out, you know, with, you know, particularly in semester 1 with Libby and fundamentals, that it's not just the theory faculty that we with 240 as well, that it's not just the theory faculty, that we would have a more robust plan for both the theory faculty and implications in clinical and in simulation and lab. To me, that if we only focus first on the integration in theory, we're missing a really big piece of this whole model. If we're not having our faculty talk the same language and really work on building clinical judgment. So
Yeah, I agree. It's kind of in the name, right? Clinical judgment.
yeah,
Clinical is key. We have to have a plan to make that happen.
so. All right, we'll revisit. I think this is really important, and I think it'll be really important as we move towards competency base and the essentials. I think it will all come together. So the number 5, we can actually kind of pull back on. I thought when I first created the draft of this outline that we were still going to move towards that new curricular plan that all of you worked on last year in condensing, to also start in fall. It's like hard to know how many new things start in fall of 23, but with all of, I guess, really, I don't know whether to use the word controversy, with all the potential changes in general ed, and other major changes occurring right now, it is Megan's opinion, I guess, along with mine, that we may need to wait 1 more year to really to not have changes twice. We have not mapped the essentials. We do not know whether we might need to add a few more, even one more course or any changes in our credits based on our mapping. We do not know whether we're going to continue to have 42 hours of general ed in the different categories that we currently have, or whether we're going to have 30 hours in general ed, which will free up quite a few credits to either allow students to have opportunities for other immersions, for a course that is currently not required that would help capture some of the essentials that we're not doing well, or not doing as thoroughly. So we've just got all these different things, and the deadline for catalog revisions is coming up. And again, the curriculum is the faculty. However, those are some really important structural or system things to think about, of whether we want to move forward or again take a little step back, do our mapping first, thoughtfully see what changes we may have in the curriculum. I know it's another whole year, things move slowly, but will we be in a better position to make one change, one major curricular change, with integration of the essentials, perhaps integration of the computing method of clinical judgment, building on whatever foundation of general ed that will be our general ed, because clearly for CCNE and for all of us, we know that our professional nursing education builds on a foundation of the arts and sciences. But at this point in time, we don't even know what that's going to look like next year. So that's my spiel. I again now turn it over to you. You're the faculty. As I said, the faculty does own this curriculum. What are your thoughts about all the hard work you did last year or whenever it was that changed some of the classes? Do you want to push ahead? Do you want to take a step back, even if it means waiting one more year?
By 1 year, are we talking fall 24?
Yes, because I don't think you can make major catalog changes in winter. So, I mean, that's a limitation of the university. We either have to have it in the catalog this November for fall 23,
Correct.
or the following November. We don't have a choice to only put it off one semester.
Yeah, winter 24 is in the 23, 24.
It's the way it is. We don't, that's a system requirement of us.
I thought that the changes that were proposed were already nixed by the university because of the budget nightmare that it caused by compressing the classes or some of the classes. I thought Megan had come into a meeting and said that, you know, we had done that and she had, what was the word she used? Fallout, unexpected fallout, that the university said that the budget would be affected so dramatically that it was delayed. I don't know, almost indefinitely.
Well, again, I can't speak for that because I wasn't at that meeting. I did hear that from my perspective of being on the RN to BSN program, when NSC 180, the legal and moral implications for nursing, it was unclear whether that was remaining required or was going to be dropped. I do remember that in the RN faculty meeting, there was a discussion that that will cause or may lead to a drop in credit hour production. However, this is my perspective. Yes, we have to be sensitive to budget, but we can't keep courses in our curriculum purely for their credit hour production. They have to make sense for our curriculum. And then we have to figure out a way to balance our budget and all of that. In terms of that whole change, I guess I don't know. I don't know. I don't know that, Teresa.
I don't think it was presented outside of the School of Nursing.
Yes, I think it was within the School of Nursing.
I don't know. I just know that there was some that Megan brought it to the, am I the only one who remembers this? Did I make it up? My own head.
I remember, sorry, I have a little co-pilot today. I remember something similar as well. Where Megan was saying, like, it wasn't, what happened is like the rearranging of the curriculum would lead to semesters where there's almost like no money coming in. Like, I do remember a conversation about this. She did bring it to us. She was saying, like, because the curriculum would get rearranged, there were certain semesters where, like, some semesters would be heavy loaded where students would be in the same class multiple times, but then there would be other semesters where certain courses would have no students. And then those were the semesters where there was like a massive drop in revenue.
I see.
Yeah.
Well, I understand those struggles. I mean, I've been enough in administration to understand that. However, I think that can't be the only driving force. So I think that there has to be a balance between how do you roll something out? But I think we have to first start with what do we need in the curriculum? And it sounds like regardless, we're not going to move forward November 1. And then I think that we need to do our mapping, go back to what that plan was, and then think about how it can be implemented. Most of the time when you have a curricular revision, there is some budgetary implications that occur and some scheduling implications, right? You might have all the students in one, but it will even out. So ultimately it has to be viable within the budget and meet student needs, but there may be temporary discussion or disruptions. And I think at that point in time is when you go to higher administration and you make your case and somehow you get through.
Yeah.
So I think we're at least everyone's in agreement. We are not ready to move forward at this point in time. So let's do our work of our mapping. Let's revisit it all over the course of the year. Megan will be back in January. So if we're well underway with the mapping, then it is a balance between what do our students need? I mean, that's ultimately, and then we got to figure out the budget and the transition. So, is that okay with everyone, the plan? I mean, these essentials have to drive some of this as well. Okay.
Yeah, I mean, there's new courses to be developed and I have no idea how we get all of that done in the right order by November 11th.
Yeah,
Like
so sometimes it's the reason why we move more
Okay.
slowly, but we don't want multiple curricular changes that every semester it's different. So it's better to be thoughtful. We've rolled out a lot of different curricular changes over the time I've been here. My goodness, if we were still doing the same thing and we were doing in 1984, we'd be really behind the times. So we have made it work before and we can make it work again. We're a changing profession and we got to meet the current needs of society and the projected needs of society. We will work it out. All right, I'm going to turn this over now to Denise and kind of go from there.
Denise, do you want screen share or do you want me to pull up the docs?
Whichever's easier for you to do.
I can just click and share right here.
Okay. So, yep, let's start with the alumni exit survey real quick because the other two are kind of related. Whereas this is different. Oh. That's the NCLEX
one.
scores.
Is that not it? Oops.
No, that's the NCLEX scores.
All right, how do I get back there? Oh, exit. Which one?
It's the alumni exit survey.
Did I put the
That
same?
one right there.
Is that pulling? No, that's oh, crud.
No,
I must have
that's still
saved it
the-
wrong. All right, hold on one sec. One sec. Let me go back to my email from you. Toggling screens, bear with me. Unless you have it handy. Y'all can watch me for a minute here. Watch me do my. Alumni exit Sky Factor. Here we go. This one.
Yes,
Okay.
please. So this survey is the Sky Factor survey, went out to the alumni. It goes out annually, open from August to August. And I was not able to find previous data to be able to compare it, but this is for this past year. And essentially the N was 59 or 51. You can see there were 21 accelerated or traditional, 15 accelerated and 15 RN to BSN students that completed the survey. So pretty a small N with these results. For the most part, I thought things looked pretty good. There was only 3 red components, and then, a few yellows. Our goal is to be at a 5. So this was kind of the results of that. So it's just, available for you guys to look at. And I think if you scroll further, I took each section and broke it down into the questions and what the score was for that. So if you're wanting to get more specific about, well, why did we score low here? This is what was asked of the students in that particular or the graduates in that particular section. So then you can kind of see how they scored. So generally their viewpoint, I highlighted the ones that were below 5. So if you're looking at it quickly, you could see that.
It's interesting that some of those support the ones I saw up above here. Like they don't want to be on campus, but then they said these were slow, these were low. Co-curricular activities.
Yeah, I know.
Who was at school? They don't come.
Yeah, that is,
Feel
that
that they
is the
will
thing.
come. I have not always seen that. So I don't know.
Yeah, so it's there for you to look at. Program eval is we're gonna meet with the dean and have some further discussions about, what metrics do we need as a school? Do we need to continue doing Sky Factor? Are there other measurements that we could be looking at? So more to come on that. So then I've got the most recent NCLEX results.
So Denise, can I just make one comment about one of the areas that was a little bit lower was regarding health policy. Number 5 in terms of the essential. This is a combination of all pre-licensure or not pre-licensure. This is a combination of all BSN, including the RN to BSN and pre-licensure. In a previous year, I'm not sure this year, I'd have to go back and look at some other documents. When we broke it out further and just looked at the RN to BSN, this number went up significantly after we require in the RN BSN program the health policy course. So we looked at this when we made our last curricular revision and included health policy as a required course. So I just only bring that up. Again, I don't know how it all fit in the essentials, but to at least share with you that looking at some of this and thoughtfully deciding whether any curricular changes, we at least within the post-licensure program experienced an example that mapping, looking at Sky Factor, making a change in the curriculum, looking at Sky Factor again, did give us some information. So just a piece to share with you.
Yeah, thank you. Okay, Maris, can you switch to the NCLEX results?
First time pass rate or the most recent pass rates?
Most recent pass rates, what I want.
It's weird. It's like they're all, I must have put them in the wrong spot.
So that one right there is the one I want.
I'm sorry. I just like open.
Do you have it open already, maybe?
Yeah, sorry. Probably.
So this is the most recent NCLEX results. This is from June or January to June. And so you've got our first time pass rates are at 82.35%. We have our repeaters at 47.37%, and then overall we're at 78.06%. So last year at this time, our overall was 87.91. So we have significantly decreased our pass rates in the past year. So, and I realize that, COVID is probably still impacting some of this, but I think it's a little bit concerning. I don't have the results from other universities yet. The Mountain Report, I think, comes out in October, right, Linda? Yeah. So once we get that, I think we'll have a better indication as to how we compare to other universities in regards to that. And then Maris, can you put up the other one? Because that one breaks down how we did per cohort. So the 53s, they had 34 that took the exam, so their success rate was 87%. The 54s, they had 26 of their students of that cohort that took it, their pass rate was 76.47. X17s was 79.49%, and the 18s were 83%. And so you can see that, there's still a few students that have to test, or they probably have by now, but yeah, but as the results here, there were 2 students that I noted that have taken the NCLEX 5 times and still have not successfully passed. So I thought that was kind of interesting too.
Elizabeth?
So just one thing that's like stuck out to me with the April 22 grads is with the 6 that haven't tested, given that, given that the N is so small, I mean, that makes a huge difference. If you take those 6 out, essentially you have 24 out of 26 that have passed, right? I mean, it's like, that's a difference between a 93% pass rate and a 76% pass rate.
Well, interesting too that you say that, because if you look at the 18s, they have 5 that haven't tested yet, right? They only had 20 that took the exam, so their sample size is smaller too.
Well, that's my other question too, is like, it says the N for that cohort's 24. And yet, if you add those that have taken it and passed and those that didn't, it's 25. So like, that's slightly unclear as well.
I can look at that. The percentages is only based on the number of testers. It excluded the hasn't tested yet, but are my math wrong somehow?
Yeah, I just think like when you have an N that's so small, that's an important distinction, right? Because that, like, if you're specifically looking at,
I see what you mean.
Yes.
We're saying the pass rate is 77%, but you have 6 students who haven't tested. So truly, of the students that have tested, only 2 have failed. The pass rate's closer to 93%. Like that's a huge distinction, no?
Right. That's what's throwing me off too, Elizabeth.
I'll check on that one differential. I didn't notice that before.
No, but I think what Elizabeth is saying is, are we getting, just for instance, if you look at BSN 54 and your pass rate or your rate is 76.47, is that based on, is that including the ones that haven't been tested?
No.
No.
Okay.
No, 26 passed on, like for BSN 54, 26 passed out of 34 testers.
Gotcha. Okay.
So the N is not the cohort total.
Okay, thank you.
So that 76 could ultimately go up higher, but it also has the potential of dropping lower. The concern is that of April grads, this is still, they have not tested. There were 11 April grads that have not tested by the end of June. Now, hopefully they have, but historically, the longer that you wait to test, sometimes they're more at risk. I mean, sometimes they need that time for preparation, for additional, classes that they may take, but over time, we used to see that those that waited longer than 3 months to take the test for the first time tended to have pass rates lower than if they took it before, earlier within the first 3 months after graduation.
Yeah, and unfortunately, we don't, know why they haven't tested by June.
Right.
And even some of the ones that graduated in December, if they haven't tested by June, I mean, there's what, 3 of them there?
3.
Yeah, so that's a little concerning too.
I could share the larger report if you want me to, Denise. It has the names on it, though.
I know, I didn't know if that was something that we wanted to do at this particular meeting.
Or I
That's
could-
why I didn't send it to you.
I could let people know, it's who has multiple fails or something today that I know about, but.
So I think some of the implications of this is in all the courses. I heard from some students this summer in the X20s, correct? They're the ones graduating this December.
No, the 19.
19s. Okay, sorry, I don't know our numbers. They were saying, they put in emails to me and in some verbal meetings that I was with that, oh, maybe it wasn't that group. It might've been one of the groups that were teaching this summer, maybe both, were saying, we don't have to focus on this. That's what the last semester is for. And they were kind of annoyed that a faculty was talking to them about that this may be important for the NCLEX, or this is relevant to the NCLEX. They were quite verbal about that. Well, that's their last semester, rather than that idea of that when you start this program, you were preparing for NCLEX right from day one. Kind of like the idea, we plan for patient discharge from settings the moment they're admitted. You don't wait until right at the end. So I don't know whether, as we're working on improving these pass rates, because we do want to stay with solid pass rates, that we all think about how students are perceiving, passing the NCLEX.
That's so strange. That's so strange.
And I will tell you, years ago, I had students say, I'm just going to take the NCLEX, see what it's like, then I'll decide how to study. Now, many of our students just don't have the economic ability to say, oh, I'm going to blow off the first test to get a feel for it, and then I'll do the second. But I wonder whether we truly, thoughtfully, even gather information about how our students feel about the NCLEX. And if they are so focusing on grades and passing the tests, our current each and every semester, that they're not embracing the full picture of preparation for practice. Just a thought.
There's a couple other things that will help clarify some of those non-testers too. When I look at the actual names of students that were not on that June 22 detailed report, 4 of those students were out of state testers. So I don't know if there's just a little delay in that reporting. I don't really know why, because usually it will specify if they're passed out of state. One of those students self-reported that she passed out of state. That's not reflected in these pass rates. Another thing is 3 of the graduates were technically August 22 grads. I was able to verify their degree completion at the end of spring, so they wouldn't have even been eligible to test until sometime in July. So that also, they're still part of the cohort, so this almost isn't complete yet. So just for that record, I'm not quite sure why some of those out-of-staters aren't reflected, but I mean, I can see when I look at the list, there's 4 of them that I'm certain were Arizona and whatever. We had Ohio, we had several out-of-staters, but anyway.
So essentially, that's what I have for now. As soon as we get the mountain report and are able to take a look at that, then we'll share the results of that too, and that might give us some more information.
Yeah.
Thanks for this report. We've got lots of things to think about this meeting. Is there anything else that is not on the agenda that we need to address today? So again, my original plan was that many were going to be, on campus, and that I was trying to leave time, at least at some of these meetings, because I know a lot of the different committees, admissions, talking about games, ASC, all of your committees, I thought to try to give some time to work together. I guess it doesn't work so well online unless all of a sudden there's different groups assigned, but that was my intent. I mean, I certainly will end early. I know that some of us are going to executive committee. Maybe the time we don't spend here, you can add some additional time for whenever your committees are meeting. Because I know that there's a lot of work that can be done in smaller groups and brought here. So I was trying to be respectful of that. So if anyone wants to go off in their other groups, or however you want to talk, or just know, I'm ready to conclude the meeting.